Heroes in Prevention is a organization-wide effort to break the chains of infection, to go beyond hand-washing programs and flu shots, to create a whole new approach to minimizing infections.
Just to make sure everybody's on the same page, we're going to go through all the rules, and then we're going to go back through them, and we're going to discuss them, okay? And there'll be ample opportunity for comments and questions. All right. And so as far as that goes, I'm going to, Chris is going to give us his insights beforehand, and then I've got about 3 or 4 slides that are going to be sort of your kind of a roadmap for evaluating these rules, okay? All right, so I'm going to turn things, are you ready for us yet? Okay. Okay, so I'll turn things over to Chris, and then once we get our, I'm kind of a low-tech person, but once we get this high-tech stuff set up, I'm going to go over just a few slides, which I'll read to you because you probably won't be able to see them all in the back, and we'll talk about how we're going to evaluate these rules. Okay?
Okay, thank you, Jonathan, and good afternoon, everyone. As Jonathan said, I'm Chris Laxton. I serve as Executive Director of AMDA, the Society for Post-Acute and Long-Term Care Medicine. I've been in the long-term care nonprofit field for almost 30 years, starting out in home care and then moving through to nursing homes. Immediately prior to this, I served as the president of the Illinois affiliate of Leading Age, now called Leading Age Illinois. Back then it was called Life Services Network. Anyone from Illinois out there? Yes, all right. I now live in Washington, so I guess it doesn't really matter. I'd like to put some historical context around what we're talking about today. As I think most of you are aware, in 1987, the nursing home reform law called OBRA 87 was passed, and in 1991, that law was implemented in the first major piece of nursing home regulation in this country. One of the things that did, really the intent of the entire piece of legislation and regulation was, of course, to set a floor, a minimum floor of standards of operational and care processes for nursing homes in this country, really to correct all of the problems that nursing homes had over the course of the 60s and 70s that really caused all of the changes and reforms that took place. One of the things that regulation set of regs did was to establish the requirement that every nursing home have a physician medical director. And from the point of view of AMDA, at that time called the American Medical Directors Association, that spurred the organization into a period of rapid growth where we had to really standardize and define the roles, tasks, and functions of a medical director, build a training curriculum to train medical directors, and then a credentialing program to credential them. Just out of interest, how many of you are aware that there is a certified medical director credential out there? I see a few hands.
Oh, that's good.
So be aware that medical directors can be certified, and from our point of view should be certified. It's a complex task to be a nursing home medical director. And without any training or proof of competency, it's difficult to really know that your medical director is as engaged as he or she should be. And so the other question I like to ask is, how many of you think that being a certified medical director is a requirement for serving as a medical director? Generally, no hands go up. Obviously, it's not a requirement, it's a voluntary credential, but from our point of view, one of the components of ensuring that patient care is of high quality is that those who are responsible for care are properly trained, are competent, and are committed to the work. And I think that while the CMD is not a guarantee of that, any credential isn't a guarantee of competence. It is at least a marker that someone has been through the adequate training and the work experience to do that. So that's part of what OBRA 87 did. And really since that time, AMDA, the society, has been focused on improving the quality of care in nursing homes, really focused on person-centered care, the fundamentals of geriatric medicine, and promoting trained, competent clinicians is the best way to achieve that. 3 years ago, to really recognize the number of changes that have taken place in the nursing home field, we went through a number of important changes in our structure. We changed our name from the American Medical Directors Association to the Society for Post-Acute and Long-Term Care Medicine. Clearly, what that recognized, among other things, was how much the focus of the entire setting of long-term and post-acute care has changed. On the acute, post-acute side, more and more patients were coming in for joint replacement rehabilitation. The level of acuity of the residents in skilled buildings had really gone up and continues to go up. But by the same token, that level of acuity kind of flowed throughout the spectrum of care: assisted living, independent living, home care, hospice. We see residents and patients coming into these settings. I'm not telling you anything you don't already know, who are older. They have multiple comorbid conditions. They have drug regimens that begin at about 9 different meds and go up from there. Many of these meds have interactions with each other that are unknown. The dosing requirements are a little bit tricky, and certainly coming out of the acute care setting, often the role of a medical director and of really any physician in the setting is to dial a lot of that stuff back. It's to sort of demedicate, de-line, and get a patient back to, or a resident back to sort of normal function. So we changed our name. We also extended our membership to include, we used to be an exclusively physician organization, but understanding that nursing home care is team care, we've extended our membership to include nurse practitioners and physician assistants as voting members. We've always embraced the full interprofessional team. And I think that's a change that will continue to function as we go forward. And then finally, as I just described, we moved from an exclusive focus on skilled buildings to the entire spectrum of post-acute and long-term care. And again, that's because that's where people are, and that's where the patient is. So, you know, I think OBRA 87 is one bookend, and the nursing home regs that we're going to be talking about today is really the other bookend between 1991, when these regs were implemented, and today, almost 30 years. We have not seen a major revision in the requirements of participation in Medicare for nursing homes and really for any long-term care settings. And yet we know from our experience of working in these places that the environment is extremely different. The complexity of the patients, the changes in the facilities, the fact that you continue to have challenges in terms of staffing turnover, in terms of facility capacity, what you're able to do on site versus having to send a resident or patient out. All of those things are changing rapidly, and of course the regulations have not kept pace with that, even though some of the financing reforms are also changing the landscape of how nursing homes work. So really some of the most important things that the new nursing home requirements are going to bring in is an entirely new section on comprehensive person-centered care planning. This, as well as one on quality assurance and process improvement, so-called QAPI. These new regs represent both a threat and an opportunity. The threat is really that, you know, like any regulatory framework, the floor that it's setting becomes a ceiling. People don't go beyond it. People see that compliance is what matters, and beyond that, no one is prepared to go. I think there's also another way of thinking about that, and that is that the portal or the gate, the doorway that these regulations represent really become a barrier. You don't walk through that doorway to go beyond it in the direction of the intent of these laws and regulations. You just you stop there for a lot of reasons. As Dr. Jonathan Evans said, I think I'll just say Jonathan and Mary if that's all right with you. as Jonathan said, I do serve as a national Baldrige examiner. One of the things that I see when I look at an applicant for the Baldrige Award is the degree to which they go beyond compliance. Often an applicant will say, yeah, we have an independent third-party auditor look at our financial statements each year. Yay. The fact is, you're required by law to do that. And so if you don't do it, you're probably going to get fined at a minimum and perhaps go to jail. So saying we stayed out of jail isn't particularly a good standard to follow. But that sort of compliance mentality is pervasive in healthcare. It's not something that's exclusive to post-acute and long-term care. It really covers the entire spectrum. The other ways in which regs can sometimes be a barrier is in their literal interpretation. As when I was in Illinois serving as the president of that nonprofit nursing home group, we had a number of members who were building buildings that were really culture change, person-centered design. They were really beautiful buildings that were home-like and had really kind of very responsive design to what people said they wanted. Neighborhoods, there were comfortable settings. There was privacy when it was necessary and so forth. There were a lot of things that just said resident dignity, resident choice. Initially, the problem with getting these buildings built and open for business was that the regulations had no way of kind of understanding what these were. They didn't look like nursing homes. They didn't behave like nursing homes. The nursing stations weren't front and center. And the regulators were kind of looking at them and saying, how do we recognize these buildings and these settings and these designs in the regs? After some negotiation and good advocacy, we were able to create a waiver that was sort of experimental in nature, but in the end, were compliant enough that these buildings could go forward, and there were indeed beautiful places where people would love to come and visit, people would love to come and stay. Families were happy. They knew their loved ones were safe and well taken care of, and they just were happy places. And and yet, if we hadn't done that work of saying, okay, how do we kind of tweak and flex these regs so that they can recognize these things, it would have been a barrier. The opportunity, though, is really kind of powerful, and that is to influence the interpretive guidance that will steer the implementation of these rules. And, and while it's true to say that between '87, when the Oberlaw was passed, and today, there haven't been a major revision of the regs, really what has happened almost every year is new interpretive guidance has come out of CMS, and that's actually where advocates can have, and I regard all of you in this room as advocates, can have an influence in turning these new regulations into a really good opportunity to take care of people the way they want to be taken care of. So speaking a little bit about regulations and quality, it's true that regulation is a pretty unwieldy tool to affect culture change. In fact, I was looking at the Pioneer Network's own list of values that's in your program, and they're inspiring. The 13 statements of values and principles for Pioneer Network. You will not find one of these in either the over 87 law and regs or in the new requirements of participation that are coming out next month. But I think the principles that inform this can be the principles that influence the implementation of these regs. And that's really where I think the opportunity comes from. So again, regs can be an enabler of tools that can and should be used to change culture. And these tools really begin with leadership. Leadership in the nursing home is what will drive culture change. The way leadership can drive culture change is by putting in place processes and systems that support person-centered care. And the major tool, and this is one right out of the Pioneer Network values and principles, is the relationships that are built between caregivers and their patients and residents, between caregivers and families, between the organization and its customers and stakeholders. So those three elements, I think, are important to remember. And to a large extent, this is really simply codifying human nature. Really, I guess, or to quote Lincoln's first inaugural, the better angels of our nature. I know we all have choices, but I think in many ways, you would not have chosen a career in long-term care if you didn't actually care about people. There's really not a lot of glory in nursing home work. You do it because there's a psychic income that you get from caring for people. And, the respect you have for elders and seniors. That's certainly why I've been doing this work for as long as I have. On a personal note, my mother lived for 13 years with Alzheimer's, and my father was her main caregiver up until the last couple of years. He was an old Marine, lived his life in the military, figured he knew everything. You couldn't tell him anything. So he figured he knew how to take care of my mom. And, there were many times when he would become very frustrated with her because she wasn't doing what was expected. And her behavior would seem to be one that was aggressive and fighting of what he wanted. But his nature was, in the end, one that he wanted to do the best for my mom. So over the course of the years, he learned to enter her world and to meet her where she was and to treat her behavior as the only communication in the end she was left with as she lost the power of speech, and was able to basically do naturally, without any training, without any regulations, without any laws, the most perfect person-centered care that anyone could give for my mom. He would go up to her, finally at the end, he would go up to her Alzheimer's ward where she lived for the last couple of years each night and sing her a song because he knew that she loved to listen to people singing and she loved music. That's, to me, a perfect example of how human nature is actually what drives the change that was needed, more than the physical plan, more than the sort of requirements that were there on this building where she lived. And I think I say this because I believe that we're connection machines, to use a phrase from artificial intelligence. We're wired for connection. We suffer when we don't have it. We sometimes die in the absence of true connection. But we thrive when it's there, and it can be there in many different forms. Nobody sat down to write rules intending to cause suffering. The adverse results of nursing home regs all fall into the category of unintended consequences. So preventing unintended consequences, I think, is the bumper sticker for what we're trying to do today, is to empower all of you to let you know that you have an opportunity here to make a positive change. Really, anyone working in these settings has the opportunity to do what they know is best for the residents and patients they care for. So my hope for you and for today is that we can collectively grasp that opportunity and make things better. Thank you.
Thank you, Chris. All right, I promised you this is going to be a very active session, okay? And I'm sure that those of you that want to get to the regulations, the suspense is just killing you right now, okay? And I'm not going to bring you along for too much longer. What we're going to do is really going to be, work with me on this, fun. It's going to be fun, okay? But it's also going to be a little bit hard. And I'm going to put you to work right now, okay? I'm going to ask you to think hard, not just about rules and regulations, which we're going to go into detail, but as Chris was talking about, I'm going to ask you to think about people, and specifically what motivates people, and especially what motivates people to do good, because that's a big challenge for each of us as leaders. So I'm going to set the stage for the rules. I'm going to give you sort of a framework to sort of think about this. Basically, here's what I want you to do. I want to have you thinking about policy, and thinking about rules and regulations. And Stephen Covey said, begin with the end in mind. So with that, I want you to think about what is the goal of this particular rule or regulation, okay? What are the limitations, as Chris talked about? And when we're talking about person-centered care, to get right down to it, can you force somebody to do person-centered care the right way, okay? Can you force somebody to care? So that's a challenge for all of us. I want you to think about that. Right now, I want you to take a moment and I want you to concentrate your vision, okay? Before we get into any rules or anything else, I want you to imagine the world as you would like it to be. To put it another way, in your mind's eye, I want you to paint a picture of what person-centered care looks like, okay? And that's the lens through which we're going to view all of these rules, okay? So you can judge for yourselves whether it achieves the goal and what the barriers and challenges are, okay? And I should tell you, by way of an apology, that's why I used the word fun in there and nobody thought it was fun, is that I teach healthcare policy, but I teach it at a law school because the medical school wasn't interested, okay? So people that are in healthcare are not really thinking about often the big picture, they're focused on the task at hand. And right now, we're going to get down to some very granular details, but I want you to keep the big picture in mind. So just by way of review, we're talking about the post-acute and long-term care space. These rules really apply to nursing facilities and especially skilled nursing facilities. That leaves out assisted living, it leaves out home care and so forth. These rules really don't apply to that, okay? But other rules are being created for home care. Assisted living, for the most part, doesn't participate in Medicare. And therefore, they don't participate in this contract, and therefore there's no federal regulation of assisted living, and there's not going to be, except as part of civil rights legislation. Because, in fact, hospitals aren't subject to these regulations. This is just nursing facilities, okay? The other thing, as Chris talked about, these places are changing. More and more stuff is happening there that didn't happen before. Think about what's not in there. Who's there and who's not there? Well, you've got a couple physicians here. If you work in a nursing home, you've seen more physicians today than you might see in a week, okay, depending on your facility. And many facilities are becoming more like med-surg hospitals, but you don't see the med or the surg. You don't see the doctor, you don't see the surgeon, you don't see the pharmacist, and so on and so forth. So as we look at these rules, think about those challenges and so forth. So that said, here's your job for the next hour. You're going to be evaluating these rules and regulations, which are an extension of a healthcare policy, okay? And I want you to do that by focusing on the patient, pardon me for using that medical term, focus on the person who's receiving the care, okay? And I want you to think about it in terms of their access to care, their autonomy, their right to make decisions on their own behalf, whether they have choices, the quality of the care, the timeliness of receiving that care, as well as I don't want you to worry about right now the cost to your employer. I want you to think about the cost to patients, okay? And as you think about each rule, I want you to think to yourself, now what is the goal of that rule? What's the problem they're trying to solve with that rule, okay? And ask yourself, what are the limitations to achieving that goal, all right? Because each one of us is going to be living this in some way, and so I'm telling you what your job's going to be over the next several years. So what are the limitations to achieving those goals? The other thing I want you to think about is what are the unintended consequences? If you work in a nursing facility, you work in a highly rule-bound environment, okay? And so if you work in a nursing facility, you have probably been in a situation where you have seen people trying to abide by the letter of the law, trying to get by, with the survey or whatever, but maybe not really accepting the spirit of the law, okay? So I want you to think about the purpose and the intention and what the spirit is here, and think about how this could basically go horribly wrong, and try to avoid that, okay? The other thing for many of you is to think about how these rules are going to be implemented and ultimately how they're going to be enforced, okay? So along those lines, I'll get to that in a second. So let's just so we have some commonality here about what person-centered care is. Person-centered care should answer this question. Is the person, or in the case of somebody who can't communicate, their surrogate, are they empowered to get what they want and need, okay, and avoid what they don't want and need? And empowerment I'll define here as being informed and having choices, or another way of saying it is, person-centered care is having power and control over your life and your care, okay? So keep that in mind as we talk about that. I mentioned that one of the stated goals of CMS's rules was to empower consumers by focusing on patient-centered, they called it patient-centered care and residents' rights. Okay, the other rules you can see here, but basically the main thing is they're trying to raise the bar, they're trying to improve the quality of care by having more competent, well-trained staff, by having physicians more involved, and ultimately, and this is important, they're trying to avoid unnecessary expenditures because there's a limited amount of money and they want to use that for the best possible purpose, not just sending people out of back to the hospital because somebody else has failed or because it's inconvenient. All right, so, and again, these rules were announced. We're going to go over them. Right now, there was a public comment period. Everybody got to weigh in. That's passed. The final rules have not been published, but they should be coming out in the next month or two at the most. And then the government is going to be developing these interpretive guidelines. And how many of you have seen what some people call the watermelon book? Okay, that's this thing about this big. That is the guidance to surveyors. Those are the so-called interpretive guidelines. The actual regulations are 4 pages. Okay, the interpretive guidelines is this big. So all of that is going to be rewritten to deal with these new rules. The implementation of these rules is going to be phased in over time. By that I mean several years. And then a new survey process will involve evaluating these new rules and how they're being complied with. So are we clear on that? All right, so just by way of review, I want you to basically think about what is the goal of this particular rule. Can you think about how it might be misguided, and if so, what you would do to correct it? Think about how you would implement it if you're in a facility. Think about if you're a surveyor or an advocate outside of the facility, how would you be able to go into a facility and tell if this rule is being followed, and more generally, if the care provided is person-centered or not? That's your job here for the next little while, okay? So, I'm not sure if I built up sufficient suspense, but with no further delay, Mary's going to talk about the specific. We're going to get down to brass tacks now. She's going to run through them once, and then we'll go back through them and dissect them in more detail.
All right. Whoops. Here we are. Well, thank you, and thank you for allowing us to be here today. I guess nobody said specifically, but Jonathan's my husband, as well as my practice partner, business partner. I think he was maybe trying to keep that under wraps.
I'm the lesser of 2 Evanses. So.
Anyway, while Chris and Jonathan were talking, I was thinking about the facility where I'm still a medical director. He and I have been medical directors in a few facilities in Charlottesville, Virginia, where we live. And we both have day jobs now that are working with large nursing home corporations. But we still maintain our medical directorships and our patient practices in Charlottesville because we really, really enjoy what we do. And I was thinking about the little facility where I'm still a medical director. It's the only place that I still see patients and don't plan on giving this up. It's a beautiful little facility in rural Virginia, and it's run by the Mennonites and supported by their local parish. And I remember, I've been a medical director and physician there for about 7 years or so, and I remember when I went there to interview for the position, I looked on Medicare's Nursing Home Compare, and lo and behold, it was a 5-star facility, and I was like, Nice. And I figured, you know, most of the faith-based homes tend to have better quality just in general. So I went there to interview for the position, and I said, you know, you must be really proud of your facility. And they're like, yeah, we're proud of the care that we provide. And I said, you know, you're a 5-star facility on Medicare's 5-star rating system. And they had no idea what I was talking about. And the beauty in that is that this facility and the leadership there focused on person-centered care and providing everyone what they needed and excellent medical care, spiritual care, psychological care, without having anyone, you know, hold a bat to their heads. Of course, you know, they know the regulations and they're following the regulations, and they were a zero deficiency-free survey for many years. And unfortunately, as time went on, they started getting some deficiencies because they provide excellent care, but they may not have the sort of regulatory nitty-gritty behind it. Meaning, you know, they do what the residents need, but they may not have the policies and procedures written and in place to support those. So it's been kind of an interesting journey with this facility. And recently, the director of nursing and the administrator came back from a big post-acute and long-term care conference that had different vendors for different items in the building. And they had seen a really cool whirlpool bath that was on display there. And the director of nursing was so excited to tell me about this. She said, you know, we want to do this. We think we can get together the money to do this. There's nothing wrong with their old bath, mind you. But they were very interested in getting this new bathtub because it's very easy to get the resident into the bath. They don't have to, you know, lift them and put them in. You know, a door swings open, they go in, and the bath fills within like 30 seconds or 60 seconds. So the resident's not sitting there in this empty bathtub naked until the water comes up to their level. And so immediately, being a compliance professional now, immediately I think, well, we need to have a policy in place, and you need to have, you know, like a sheet that documents every time you have a bath and clean the tub and everything. And they're like, well, of course we would do that. But, you know, in our environment now, we have to have the policies in place and the documentation in place, because otherwise it's just a risk for that kind of facility. So anyway, that's my little story. So Chris and Jonathan have talked a bit about the regulatory changes that are coming. They're supposed to go into effect this year. The final rule is pending. And I have to say, when this first was published about a year ago and public comment was invited, I was probably one of the few people in the company I work for who actually read all 443 pages or so. And I was prepared, you know, kind of, you know, coming from the background of course we're going to provide excellent care and give people what they need. I was prepared to not like this set of regulations. I don't know if any of the rest of you experience that, but I tend to think, you know, government intervention may not be such a good thing. And I'm happy to say that I was really relieved reading through all these proposed regulations that I liked all of them. And I felt like, well, this is a good thing. This is a good thing. Of course we want to have this. Of course we want to have our residents have these things. And I was also really happy to say that the corporation I work for already had a lot of these in place and policies and things like that. So I can't argue with these. The interesting thing is, like Chris mentioned, this is the first major update to nursing home regulations since the beginning, since OBRA 87. And it affects almost every department in a post-acute and long-term care facility. And the goal overall is patient choice, dignity, and person-centered care. Just last week, I don't know if y'all read McKnight's Daily News, have that pop up on your news feed. Friday, I think, there was a blurb about this. There was a letter sent to CMS from more than 30 Congress members urging additional changes, additional heightened scrutiny of some of these proposals. One of them was about nursing staffing, and they asked to require 24/7 RN staffing in buildings. Currently, they're required to have, I think, 8 hours a day of RN staffing, but can fill the other hours with LPNs, and that the current RN staffing can include administrative staff who aren't actually taking care of patients. And I'm just going to run through these. It seems like this is kind of piecemeal, but this is how the proposed changes came out. Another one was not allowing facilities to require arbitration agreements on admission. This letter to Congress from the Congress people also wanted to require written informed consent when physicians are prescribing antipsychotic drugs. They wanted increased scrutiny of transitions of care, including not allowing buildings to dump patients who were behavioral problems, for instance. You know, sometimes facilities that don't have the skills and knowledge to take care of residents with dementia and behaviors send them out to the emergency room and then tell the hospital, we're not taking this patient back, we can't handle this patient. So it's intended to limit facilities' ability to do that. The major themes in these proposed regulations, who's read all these, by the way? Has anybody gone through all this? Good bedtime reading, isn't it? So some major themes, of course, person-centered care. It supports the quality assurance and process improvement process, which I think is excellent. It looks at resident assessments, resident rights, the discharge planning process, some about physician services. One really nice thing, I think, is it talks about staff training across the board, and also putting in place a compliance and ethics committee in the facilities. Some of the specific points that are brought up, one is recognizing the validity of all marriages, which is a new provision. Some language asks to clarify decision-maker status. Some words about improving the compliance to the Elder Care Justice Act. Also includes provisions for making sure that communication assistance is available to residents who may be visually impaired, hearing impaired, may not speak English as a first language or main language, and also allowing for electronic communication. Another interesting provision in this is requiring an annual facility self-assessment. And the reason for that is that we all know that every facility is different. They each have sort of their own personality, even different facilities within a particular company. We know that some facilities may sort of specialize in orthopedic care or psychiatric care or cardiac care. And so this recognizes that facilities are different and that their staffing levels may need to be different. So they're asking that facilities do a self-assessment, find out really what their clinical capabilities are. You know, as our space is changing, patients are coming into post-acute and long-term care facilities much sicker than they used to, and now we're sort of seeing post-acute and long-term care facilities function kind of like a step-down unit. And they're advocates for putting ventilator units in post-acute and long-term care, which was unheard of 10 years ago. We want to make sure that the staff are appropriately trained and demonstrate competency in taking care of these sicker patients. The facility assessment also wants them to look at the physical plant and the layout of their facilities, and also make sure that they're culturally competent and ready to accept diversity. The proposal includes provisions for improved care planning, that care plans must be done timely. And these things, as I go through, you'll see, well, these are all things that we should be doing already, right? And I think a lot of good buildings and good companies are already doing these things, are going above and beyond the regulations that are currently in place. This sort of sets the bar higher, like Chris and Jonathan have mentioned, and makes, going above and beyond sort of the baseline. The proposal specifies particular IDT team members, interdisciplinary team members, focuses on discharge planning, including that you can't discharge a resident for non-payment, like some facilities have tried before. The facilities need to document the efforts to meet the residents' needs and how the receiving facility can meet those needs when patients are being transferred from one facility to another, and also visitation rights. This is a particularly good proposal in the area of discharge planning. If you work in post-acute and long-term care, you know the frustration of receiving a resident on Friday night with no documentation. I'm sure nobody in this room has ever experienced that, right? Happens all the time. So I was really, really happy to see this provision in the proposal, that it will require more comprehensive information upon transfer of a resident. And this also applies to residents who are leaving post-acute and long-term care and going to a different level of care or going home, that this information should be communicated to their primary physician in the community so that they know what's happened if somebody's had a short stay in a skilled nursing facility, including demographic and contact information, a list of their medical problems, their cognition, a summary of their lab test results, an indication of any advanced directives that are in place, a list of medications that's updated. I mean, this all seems like intuitively obvious that you would want to include these things when you're transferring a resident, but we all know that this doesn't happen, I would say, the majority of the time, unfortunately. One area that's gotten the physician community a little riled is in the area of physician services. Recommended in this proposal is that any resident who is transferred to a hospital for an unplanned reason have an in-person evaluation by a physician, a nurse practitioner, a physician assistant, or an advanced practice nurse. We were particularly a little happy to hear about this because, we believe the model that is going to work in our space is going to be physicians who are in the facility a lot. Not the physician who stops by once a month or every other month or shows up for QAPI meeting and then leaves. We really believe that the best care can be provided in a post-acute and long-term care facility where the physician and medical director are really an integral part of the leadership team and weigh in on different aspects of the care there. There's an exception to this that if there's a true emergency, they can waive the requirement to see a physician. Another area indicated in the physician services is that physicians would need to give a written response to pharmacist recommendations. Pharmacists are required to review the medication list periodically and make recommendations for dosage reduction trials of psychiatric meds. And that's been implemented pretty well for the most part, but I know there are several buildings where physicians just don't respond to those recommendations, or they respond and the changes never get made in the orders. So this kind of strengthens that regulatory aspect. I think that's a really good thing. Also, if a physician declines doing a dosage reduction or discontinuing a medication, there's now strengthening to require a written rationale for not heeding the pharmacist's recommendations. Jonathan and I have been advocates for many years about person-centered care, non-pharmacologic management of residents with dementia and behaviors, and getting rid of antipsychotic medications. And I'm happy to say that today in 2016, this is not so much an issue that it was 15 years ago when physicians were not interested at all in hearing about this. So one of the provisions here we're very happy about, the push to decrease unnecessary drugs with gradual dosage reduction and limitation of prescribing as needed psychotropic medications to 48 hours. We all know, if you work in this space, that the nursing staff may call the physician and say, you know, Mrs. Smith is out of control, we need something to control her behavior. And in the past, physicians may have prescribed an anxiolytic or an antipsychotic medication, you know, as needed, boom, it goes on the chart and it never disappears again. It's never looked at again. So this provision would limit that PRN psychotropic medication to 48 hours after the initial incident. I could talk all day about this, but I won't. The proposal also addresses staffing and training of staff in the building. They're talking about mandatory staffing levels, doing staff evaluations of their knowledge base and their competencies. They're talking about altering staffing based on resident acuity, which is a really good idea. They're requiring staff to have training in mental illness and particularly in the area of post-traumatic and stress disorder. Requiring an infection control officer, not just having this data reviewed at a QAPI meeting, but having someone who's designated to really oversee the infection control program. Also adding compliance and ethics training and having a compliance liaison in the building if the building is owned by a company that owns 5 or more facilities. So as a compliance person, that made me happy. Also requiring staff to have specific dementia care training, abuse prevention training, and behavioral health training for all staff, not just nursing staff and CNA staff, but for all staff in the building. And also requiring staff training for consultants that come into the building, vendors, volunteers, that kind of thing. So any physician or service that's coming into your building should also be trained in those areas. This was a really great recommendation here, is to limit in new construction of post-acute and long-term care facilities, limit the rooms to only having a maximum of 2 patients. So gone, hopefully, will be the quad rooms and things that we see sometimes. And also requiring that the rooms need to contain a shower, a toilet, and a sink. So hopefully gone will be the mass shower rooms that we see currently. And that's where I'll end sort of this brief overview of the proposed regulations, and we'll have more discussion of this as we go on. Thank you.
All right, so that was a kind of a quick run through of the proposed changes. Now we're going to do a little deeper dive on the specifics, and I'm going to challenge you a little bit, and this is your opportunity to ask questions and make comments as well. So let me go back here. I'm going to start by asking you a question which I asked you earlier, this time a little bit more broadly. What's the goal of regulation? To assure that people are going to get the care that they need and should have. Well, that's a great goal. Okay, I'm all for that. I guess I'm gonna be a little less optimistic for starters, and then I'll come around to your way of thinking, because I agree with you completely. One goal of regulation, of pretty much any regulation, is to put rules in place that require other people to create systems and processes that make it harder for people to do the wrong thing, okay? That's like the minimum, making it harder for people to do the wrong thing. our challenge, each and every one of us here, is to put systems and processes in place to make it easier for people to do the right thing. Because if we want to get people to where we want them to go, we can't settle for that minimum standard. So, but again, as we talked, I mean, Mary talked about the goals of a lot of these things. We're going to look at them a little bit more critically and talk about what could possibly go wrong, think about how you would measure this, how you would evaluate it, how you would tell people to do it, okay? So, and I'm going to, just to get the ball rolling, I'm going to toss out some questions, but I encourage you to just jump right in. We have a microphone we'll pass around so that everybody gets to have their say. All right. So I'm just going to go through each one. I'm going to read them out. Anybody who wants to make a comment or ask a question, stand up or raise your hand and we'll give you the microphone. Recognizing the validity of all legal marriages. Is that going to be a challenge for any of you in your facilities? If you're trying to determine whether they have a, if you, all right. It's not going to be a challenge for any of you to comply with this? How will you know if any of your residents are legally married? I'm taking this one and making it kind of silly here. Are you going to require a marriage certificate for everybody that comes to your facility?
What about the people who have lived together 10, 20, 30 years and have not been married? I had a couple that got married a few weeks before they came to the facility so they could live together.
Okay, and there are also stories about people getting divorced so one of them doesn't go bankrupt because they're in a facility. And there's common law marriages in different states that are respected in different states. Basically, what this rule is saying is recognize the validity of all legal marriages. If they were legally married somewhere, even if they were legally recognized as a common law spouse, then they're saying it needs to be recognized where they are. And I'm not trying to, I don't want to spend an hour talking about marriage, okay? I mean, I'm just basking in the glow of being married, okay? So, but. No, so again, I'm just using this one example. I'm just using this one example to point out that even something that seems straightforward, that you've all agreed is a good idea, you know, someone's gonna have to do the hard work of actually figuring out the details, okay? And that's important work. I'm not disparaging that. I'm just want you to think a little more deeply about the implications of some of these things. All right, clarifying the decision maker status. Any problems with that? As you're thinking about how you're going to implement that, do you have a plan in mind? How do you know who's the decision maker? How do you know who's the decision maker when the person that's there is obviously not the decision maker? Okay? So there's obviously some limitations to that, right? Elder Care Justice Act compliance. One of the big things that the Elder Care Justice Act did is it basically made a federal law that sort of superseded state laws that essentially say if you're a healthcare practitioner, if you work in a nursing facility or any healthcare setting, you are required to report suspected abuse, neglect, or exploitation, not just to social services, but to the police, okay? The key word there, the key problem actually is suspected. Okay? Many facilities don't report anything because they say, well, we investigated it and we don't suspect anything. So, you know, you have to define suspected. How suspicious are you or not? Okay? So you see where I'm going here? Smelling what I'm cooking? This is what I want you to do with each one of these things. Okay. Communication in alternate formats. I guess let me ask you this question. What could be a problem with any of these things for your facility? Having people who are blind or deaf, who don't speak English, who maybe Stephen Hawking becomes a resident of your facility and uses electronic communication. Can you do that? Are you able to do that tomorrow or next month or next year? No. So what are you going to do instead? Okay, so I'll paraphrase what she said because you couldn't hear that. Let me tell you about an existing law. There's an existing law right now that says you can't take people that you can't take care of. That's the law of the land right now. It's been the law for 30 years. That same law says you must take people that you can take care of, okay? So that means if they have Medicaid only and you have an open bed, you must take them. Have you seen that one broken? Okay. Have you seen facilities cherry pick? Have you seen facilities bring people in that they can't take care of? In fact, there's no way they can take care of them because they don't even know what's wrong with them, okay? So that's the law now. We're not even talking about raising the bar. So to your point, if you can't do this, you can't take the person. So again, from the perspective of the person, now that's an issue of access to care. This rule here is intended to improve the quality of care. But facilities that can't do that aren't allowed to take that person, and now you've limited their access to care. So that's a tension that you're going to see. It exists now, and it's going to be perhaps more so. As you keep trying to raise the bar and hold people more and more to account, number one, there will be more cherry picking, and number two, there will be instances where, for good reasons, they will say, we can't meet this person's needs here. That's the law now. It's not being followed a lot of the time. And so that creates a bigger societal challenge, okay? So when you look at it at the perspective of one person who needs care, can they get it in their community or not? That's, look at it that way. Look at it also from the perspective of what would happen if fewer and fewer places are providing better and better care, and there's fewer places for people to get any care, okay? All right, so that's where we're going with this. A self-assessment done by the facility. Could you do that? Would you expect everybody to believe it? No? Would you expect your marketing, who was going to do this in your building? Your marketing director, the director of nursing, the ED? Who would you want to do it? Everybody. Okay. All right. So, but I gather from some of the murmurings that some of you have some misgivings as to how valid or useful that might be. Okay?
It depends because, for the state of Colorado, we're doing P4P, pay for performance,
Sure.
and then you also have the behavioral health add-on. So we are already doing those assessments from families, residents, staff, to kind of gauge the programming that we're implementing. So.
Excellent. Well, that's great. So I'm not trying to burst your bubble here. I'm just trying to. Part of my job is to point out hazards or ask you to think about, we're paving the road to hell with good intentions here. Okay. I'm just pointing out some of the road signs along the way. Okay. Look, and as Mary said, like her, I believe in the spirit of all these things. I want to see that spirit honored. What I'm talking about now is think about the spirit and the letter and how that can sometimes get confused and so forth. All right. Appropriate training and competencies. Any concerns about that? If you're having to implement? So you go back to your facility and say, great news, we're going to start doing appropriate training and competencies next month. What question are you going to have? What competencies? Who determines that? Who's going to do the training? What training? And so forth. So it sounds great. Obviously, this is where, if this is going to be meaningful, all those details got to be worked out. We don't want unacceptable variability. Please chime in. There's a microphone at the end there. So, sorry. I didn't mean to make it so you couldn't talk. Yeah, sure. All right. I'm just reading through the list here. Okay.
I was just going to add, No, it's on. You got to wonder who's going to provide the training. Most likely it's going to be outside sources, companies that develop this training. Who's going to pay for the training? How are they going to do the testing for competency? What happens if somebody doesn't pass the competency? What if nobody in the building passes the competency? These are all questions that, these are all really, really good ideas, but there isn't a lot of discussion in the proposal about how these things are going to be implemented or who's going to pay for them.
Yeah, and my fear here is that the training becomes all that matters, right? So what about the whole person? Does everybody need interventions in behavioral health? No, some of them absolutely do, and you need special training for that, sure, but what about the whole person? Training around understanding the needs of the whole person. Because sometimes these training requirements mean that's all that matters now. We're just going to focus on these disease states. For too long, medicine has divided people up into body parts and disease states. We're here to do something different. We're here to say, look at each person as a whole person.
So, and obviously, another thing you're hearing is that while these rules, I would say, are a great start, there's a lot more work that needs to be done, and everybody in this room has a role to play in that. Okay, everyone in this room can help figure out how to make these things come to life. So I'm going to read through each one. If you have a comment, I'm not sure, I'm only reading through them because I'm not sure if you can see them all. Please stop me if you have a comment or a question to make. On a few that are maybe more controversial, I'll challenge you.
On the last slide, it talked about, wait, I think you went too
I went
back.
the wrong way.
Maybe.
Okay.
The physical plant of the facility, I
Yes.
think that that's most concerning, especially with so many older buildings, and then the need to go to two-person and to have a shower on site. The training and the behavioral health and looking at PTSD and, I think we have active movements in place that are pushing us towards that direction and necessity for person-centered, person-directed care. But that stands out to be the scariest, I think.
So I'll just, let me add to that. So there's concern, you're talking about the building and having to possibly change the building. So for the most part, existing buildings are essentially grandfathered in. They're not being asked to make significant changes in their physical plant now. So that's good for the building owners and operators and maybe even the current residents. It means they're not going to be displaced. But in many states like Virginia, Minnesota, other states that I've lived, there's so little in the way of new nursing home construction that, in effect, in those states, there's going to be minimal impact on any kind of changes in physical plant because the states aren't really allowing a lot of new nursing homes to be built anyway. Where this may be an impact is if somebody's trying to move beds or make a significant remodel or add beds. And that's an issue. The other thing is, right now, as a practical matter, all hospital construction, I'll start with hospitals, pretty much every hospital that's adding beds or changing beds is making everything private rooms because they're concerned about infection control. Virtually every skilled nursing facility that's being built is focusing on Medicare patients, not long-term patients, and they're making everything private rooms because they don't want to cohort people that have diarrhea or something like that. And from a marketing standpoint, if you had a choice between having a private room and a shared room, which would you pick? But that also points to the fact that these rules started out for a place that was all about long-term care, and basically many of these facilities 30 years ago were God's waiting room, where the people were going there and they were never going to leave except to go to the hospital or to the cemetery. And that's changed a lot. Now 2/3 or more, about 3/4 of all admissions to nursing facilities are for short-term care, okay? And so, it's a very different population. And the problem there is, you've got these two opposing forces. All of us that are committed to person-centered care and long-term relationships with people, and a desire to dislocate hospital care from the expensive hospitals, essentially, to nursing facilities. That's pushing a lot of people out. It's making it harder for them to get in. And most people think, well, if we want to have hospital patients, we've got to make it look like a hospital. And so the more of that stuff you bring in there, the less it looks like an Edenic place for long-term care. Okay, so there's some other tensions that are market forces, and there are other forces that go well beyond these regulations. So some of these regulations are going to have minimal impact because of that.
Hold up.
I'm sorry.
I think the impact would be good of having private room, private shower. I mean, what a sense of autonomy to have your own space and to have your own environment. Then moving in with a complete stranger after your whole life, that you've had. Sorry. So
No,
it's good, but just I don't know how that impact is going to.
Yeah, so I bet everybody in this room agrees that private rooms is a good thing, with the exception of people that really want to have a roommate and don't want to be alone. And all I'm saying is that as a practical matter, it's going to take many, many years for that to be impactful because it primarily is focused on new construction, of which there isn't that much in a lot of places.
In order for the facilities to maintain competitiveness in the industry, they are going to have to take that physical plant and do renovations, because person-centered care is with the single rooms and making a more home-like environment, or they won't be able to survive.
Well, so the comment was made, that's very important, that if you want to be competitive, that you have to have a nice place and you have to provide nice care. Am I saying that right? Okay. Yeah, it has to be more person-centered. That's what people want. The question then becomes, how much of what happens in nursing facilities is a result of competition? How much competition is there in your town for Medicaid-only patients with dementia? Or how about a young male patient with a head injury? So those market forces are real and they make a big difference. It's focused really on the high dollar, post-acute, from the hospital patient, the knee and hip replacements. Not so much the hip fracture patient and a little lady with dementia who's going to need to live in a nursing home the rest of her life. So these are really important. That's why, frankly, you have to have regulations to deal with the market failures, to deal with what the free market can't do. So regulation has its place. Part of what we're saying is it also has its limitations. All right, timely care plans. Any problem with that? Any questions? What's timely? Could the quality of the care plan suffer if people are in a hurry and just trying to get it done without doing a good job? The IDT members, actually involving, part of the details here involves having a CNA present at every care plan meeting. Who's in favor of that? Anybody not in favor of that? There are some practicalities there, okay? Obviously, the certified nursing assistant has the most physical contact with the resident, arguably knows them better. Of course they should be involved in their care plan. The problem is we're asking somebody whose job it is to take care of somebody to stop taking care of them and go to a meeting, okay? And that's the challenge with all of these things. When we started having minimum data sets, we took the most highly trained nurse in the building and said, okay, we took this closet and made it your office, and your job is to do paperwork. Okay. Can't discharge for non-payment. For it, against it? Comment?
Hold up right here.
On that one specifically, but on a lot of these, my concern as a former ombudsman is that in my homes, I wasn't seeing that even the floor that exists now was being met, especially for discharge planning. It's pretty clearly laid out what you need to do to write up a discharge note or things like that. And time again, we were seeing people discharged for things that didn't make sense. There was excuses being made up. And with cannot discharge for a non-payment, the concern is that they're going to find some other reason to discharge them. And that even though hospital dumping is, something that's also banned in these rules, that we may end up seeing more of that to get around the non-payment issue.
Thank you for mentioning that. So those are some of the unintended consequences that people will try to game the system and do something else. One of the biggest...
John, another comment here.
Oh, please, go ahead.
I guess as an administrator, I'm kind of looking at that on the other side. We currently have someone who the family has just not paid for 4 months. So, we have started to put liens on things and things like that. So, I agree if it's for a different reason, but when someone's just not paying, how far do you let it go? You end up with $40,000, $60,000, $80,000, and how are you going to get that back? Then you have to hire a lawyer. You have to, do a lot of jumping through hoops to collect the money and it's not the resident usually that's the problem. It's the family that we see.
This is exactly the discussion we were hoping would happen, so thank you for that. Obviously, there's more questions than there are answers, but we want to get you started thinking about it and thinking about what some of the negative things are and how you can mitigate that, what some of the unintended consequences are. I can tell you that here's what I expect will happen with this. I mean, where I live, the biggest source of non-payment is people who are Medicaid eligible, but the hospital never did anything to help enroll them in Medicaid. And by law, virtually no one else can help them because the facility or the hospital didn't do the UAI. And so people are advertised as having a payer source when they really don't. And so what I anticipate is going to happen, and I'm not saying this is a good thing necessarily, one thing that's going to happen is if there's, in a competitive environment, if you aren't certain that they have the means to pay, many of those people are going to find it harder to get care, okay? And many of those people, if they were in the hospital, will just be sent home. So that's the other side of that. In the ideal world, hospitals will do a better job of doing their job, but in reality, a big part of this is trying to get hospitals to get people out sicker and quicker and have somebody else take care of them. So the likelihood that they're going to invest more resources in doing their jobs is a little bit low.
1 second. Hold up.
Okay.
So I need to put a positive spin on this.
Yeah, sure.
Wouldn't you say with the push to reduce readmission rates, even for the hospital, gives us a playing ground to where we can have collective thinking, collective conversation in regards to get those needs met on that side, including back history for care planning, for the financial planning, et cetera, because that decreases that patient's readmission rate into the hospital system. Because the majority of individuals that are seeking the Medicaid are maybe even borderline homeless, because I know in the communities I work, that's what we're looking at. And they're coming back to that hospital system over and over again. So if we take that time on the front end, it decreases the likelihood of them readmitting and finding appropriate, least restrictive environment for them. And so that conversation is taking place in ours. We've have programming going on with the hospital for continuity of care.
So those are great comments. I'm not sure everybody heard all that, so I'll just summarize or paraphrase some of that by saying that there are other forces at work that involve the government. For example, to hospitals for discharging people and having them bounce back, and now coming down the pike is penalties for nursing facilities. And so that's not even part of this regulation. So there's other factors, and there's no question that the intention of all this is to get people to work together. What the problem that we're trying to solve with that is a single episode of illness for one person is fragmented across multiple settings and multiple practitioners, and things break down across these transitions, and many people are pushed to another site too soon, or the site is not prepared to take them. Good care planning begins prior to admission, okay? So there's lots of things that are happening together. It's not just these regulations, and I'm glad you're thinking about how these things kind of dovetail. And again, we view these things as positive. From the Pioneer Network perspective, we've been demanding this for 20 years, okay? And we're happy about this, but it's not enough. It's a start, okay? So how about, I'm gonna skip over this. We're sort of running out of time here. A couple things I just want to ask about. We talked about the in-person evaluation by a physician, PA, or nurse practitioner prior to sending them out. Any problems with that? Would the problem be getting a physician or nurse practitioner actually show up? Okay.
In western Kansas, there aren't any that are that close. The doctor may be 60 miles away in the town he lives, and then you've got this little nursing home out over here, because there's nursing homes in a lot of the little towns, but there's not a lot of doctors out there. So you're not going to have access to that doctor.
So this is an access to care issue from the standpoint of getting the care you need in the facility. Similarly, what if somebody really needs to go out, okay? Who's to decide whether it's an emergency or not, okay? Demanding that they stay until the doctors show up may deprive people of necessary care. The other thing is, who decides what's an emergency? Or I guess let's solve this right now. Let's move the ball forward and say, we're going to define right now what's an emergency and what's not. Okay? Somebody's got to do it. Why not us? Tell me how you would make a rule for this. Do we have any surveyors here?
So I'm not defining an emergency, but my question is, whose responsibility is it? Is it the physician's responsibility or is it the nursing home's responsibility?
That's a very good question. Whose responsibility is it? These rules, obviously a lot of it has to do with physician conduct, seeing people, providing medically necessary care. There are lots of existing rules about that. People have to be seen a minimum of every 60 days. Those rules get broken all the time. The problem, if you work for a nursing facility, is you are frequently punished for the sins of others. Because this is a contract between the nursing facility and the government, not between the physician and the government, okay? And so if your physicians are bad actors, you will suffer even more. Okay?
With the physician, when this lady was talking about the rural area and the doctor 60 miles away, we were looking at telemedicine. They have telemedicine now where
Yes.
you can have, live physicians to look and you can work with them. And also, when you were talking about how everybody needs to be interconnected. With high tech, you should be able to have interoperability so that everybody will be able to be on the same page, so we're not having people run into the same thing in a circle, their conversation, and everybody knows where everybody was at and where they should go.
So those are great points. I want to make sure everybody could hear them. Technology may be a big assist in a lot of these things. Telemedicine may be something in rural Kansas. I'm not suggesting that it's equivalent to somebody being there, but there are ways that some of these things can happen more easily with electronic systems, communication, and so forth. The only thing I would say, those are really important points, and that, in fact, I think it's expected that because the government has spent a whole lot of money investing in EMRs, that they will be used for this purpose. All I can say to you is we must never expect more from technology than we expect from ourselves. So we can't expect technology to love and care for other people.
The comment I wanted to make, I am an administrator, that this regulation it concerns me. But like the question that you asked, like who's responsible, who's gonna make that decision? For the most part, it's that charge nurse that's on the shift, and of course they're going to be concerned about their license, and of course when she or he calls the doctor, then the doctor, it's his concern, it's his license or her license. So, and especially because I've been in rural areas too. So that does concern me because, you're not going to have that doctor come in at 12 o'clock at night, and that decision needs to be made.
So I appreciate your mentioning those. So just to paraphrase, we're talking about access to care, just allocation of scarce resources, scapegoating individuals, a culture of fear, particularly for physicians who don't want to get in trouble, and a lack of accountability for people. I'll just say, like a lot of things, I consider this to be very well-intentioned, and I support the spirit of this. The question is going to be, how are we going to implement it in a way that's reasonable? And since I asked the question about how do you define an emergency, I'll just tell you a very quick story. The night before I was supposed to take the MCAT exam in college so I could hopefully become a doctor, I decided to take the day easy and relax. I went fishing. In the middle of the night, I had a dream that bugs were crawling all over me, okay? And I woke up and there was a big tick stuck to my head, okay? And I thought, I'm going to get Rocky Mountain spotted fever and die before I even finish this exam, so what's the point? So I called the emergency room, and they said, there was a recording that said, we do not give out advice over the phone. If this is an emergency, go to the emergency room. Well, I actually waited to talk to somebody and said, didn't you hear the message? Okay? So if you ask the emergency room what's an emergency, they're going to say if they didn't die and they didn't get admitted to the hospital, then it wasn't an emergency. If they were admitted to the hospital, they'll say, why didn't they just get admitted directly? Why did you send them to the emergency room? And if they did die, they say, well, it wasn't our fault, so why did you send them anyway when they were just going to die? Okay? So if you're the government and you're going to have to define what an emergency is, and everybody's got a different definition, you might say it wasn't an emergency if they weren't admitted to the hospital or they didn't die. That would be one standard, and you can see a lot of problems with that. So anyway, go ahead.
It's quick. I just was thinking, like, where is the resident in all of that little statement there about?
Yes. So
If
I
they
thank you
say
for
they
asking
wanna go.
that question. So this is all. Some of these things have as an intended goal person-centered care. Let me jump ahead here. Let me just say that there are certain of these things definitely have as a goal of sort of person-centeredness, and I have a list of some of those. Some of them do not. Some of them may have a goal of improving quality, but sometimes at the expense of patient choice. And if my mother feels like she's not getting what she needs and wants to go to the hospital, she should go to the hospital, no matter what, okay? I might question whether she should go to the hospital because I have concerns about the hospital, but I'm never going to question her right to get what she needs, okay? Especially having paid taxes her whole life to get Medicare. So just to let me summarize some of these things. Some of the things that really empower consumers, we've got limits on mandatory arbitration agreements, greater control over the choice of roommate and moving rooms. We didn't go into all the details. Greater scrutiny of the use of all medications to make patients behave, attempting to increase resident involvement in care planning and decision-making, greater protections from abuse and mistreatment, greater access to medical information, strengthening requirements for privacy, notification of change in condition and care plan, and a grievance process and an officer to do that. These are all big wins for person-centered care and for everybody here, okay? Some of the things that really are focused on improving quality, I'm kind of summarizing, a more rigorous quality assurance performance improvement process with a trained QAPI officer, more rigorous infection control process, which includes infection control training and an infection control practitioner, mandatory training we talked about for dementia care, interim care planning within 48 hours, staff qualified to perform and initiate CPR, strengthening, which by the way has an abysmally low success rate in almost every setting, but that's an aside. Strengthening qualifications for an activities director, discharge planning, medication reconciliation prior to discharge, limiting the use of as-needed psychotropic drugs. You can't charge a resident for supplements or lost dentures. We didn't talk about that. And having a robust compliance program. So these are things that really should improve quality. And again, we'll begin with the goal in mind. These are obviously, it's easy to see what the goal is here. There's obviously, we talked about more physician involvement and oversight as an intention. We talked about the competing forces. Lots of things that people need in facilities aren't there. I'm skipping over this because you can read this. These things will be posted very shortly to the website. Misty Frank is going to help me overcome my technological limitations. I just want to summarize in case our time is going to end in a couple minutes. I want to summarize for everybody, but I want to invite all of you to stay that have questions or comments, and we'll stay here for as long as you want. But the fact of the matter is, change is coming, okay? The bar is being raised, expectations are rising. There's some hazards for patients, for practitioners and facilities. We pointed out some of those. But I would also point out in the midst of unprecedented change, not just the regulations, but the changing environment and changing populations, there is an unprecedented but time-limited opportunity that we have to seize, okay? I would also say, and we didn't get into this, but the changes that we want, I don't think there's anybody at this meeting, much less this session, that says they only want person-centered care, they only want quality in nursing homes. I don't think any of us believes that, okay? The fact is these rules only apply to nursing homes. The bar is only being raised in nursing homes. And in any one of your facilities, if somebody were tied to the bed right now, I guarantee you one of your staff would call the police. They would say, this is outrageous, this is illegal, and this is immoral, and they would expect someone to be arrested. Would you agree with me on that? And you can go down the street to the hospital that they're going to be sent, and you can walk down any corridor, and someone is tied to the bed, just like that person, and everybody around them is saying, this is what we always do, and it's the best thing, and it's the highest quality of care. So we have a major challenge and a major opportunity, which is to make sure that our vision for person-centered care is not limited to the walls of a particular building, okay? And I just would say, finally, that our biggest task leaving this room is each one of us must be the change that we wish to see in the world. Regardless of our position and how powerful we are, regardless of our experience, the changes that we seek will only come because of us individually and because of you specifically. So thank you for that. We're going to take more comments. We can go back through here, but I want to make sure that if you have a lunch plan at noon that you have plenty of time to get going. So thank you very much.